So good evening once again. So this is a Dungeon and Dragon series, and today we are going to discuss a very interesting case scenario because there are so many questions in your examinations in which they are asking you about hyponatremia. It is of various type. So first I will discuss the question, and then step by step manner we will discuss what can be the different types of diagnosis and what is the concept and basically the physiological concept behind that clinical scenario. So let me start that, and if you have any doubt, okay, you can comment in the comment box so that we can interact and make it more and more interesting. Okay, so let us start this. So good evening Bharat, good evening Bhavya, everyone good evening. So first let me read question for you, and then we will discuss step by step what can be the different scenario of this question. So please everyone come fast online, because if question is over it will not be understood. So join us from the beginning only. You need a great degree of focused attention. Okay, which waves are there in focused attention? You might be knowing that. Yes, anyone? Gamma waves. If you do EEG, there are gamma waves. So we need a lot of focused attention for this 30 minutes. So please promise me focused attention, then I will discuss that. Okay, so let us discuss the question. A 26-year-old woman, and this question was given to me by Dr. Sampath. So he is also online. So he asked me this question, and I have promised that I will discuss this today. So a 26-year-old woman is recovering on the ward following a subarachnoid hemorrhage 6 days ago. Okay, so she has a history of subarachnoid hemorrhage, and she has been managing to maintain her oral fluid intake above 3 liters per day, and her heart rate, you can see it is 72 normal, and BP is 146/88. So it is not hypotension. So each and every point is very important, crucial in making the diagnosis. History of subarachnoid hemorrhage. Okay, heart rate is almost normal, BP you can see a little bit higher side. At rest, her fluid balance shows that she is at net positive 650 ml over the last 6 days. So net positive and net negative. If we are taking more water, okay, and urine output is less, it is net positive. So it has net positive 650 ml over last 6 days. Her daily blood shows the following. Now this is the lab report. You can see hemoglobin, platelets, WBC, neutrophil, lymphocytes, sodium, potassium, urea, and creatinine, and CRP. What you can notice here, good evening Dr. Jabuti, good evening Dr. Midul, everyone. So please join. So in this you can see very easily, you can note that patient is having hyponatremia. If you can see here, patient is having hyponatremia. Okay, you can see that a bit urea, creatinine, they are also on the lower side. So this is also important. These all points are very important. Good evening Oris. So these all points you can see they are on the lower side. Creatinine, okay, uric acid is not given, otherwise there is also diagnostic. So these are on the lower side. Okay, now paired serum and urine sample shows the following. Serum osmolarity, you can say it is hypoosmolar hyponatremia. So you can see by this laboratory, you can see it is hypoosmolar. Osmolarity is less, and hyponatremia. Okay, and urine osmolarity, you can say it is also very much hyperosmolar, isn't it? And urine sodium is greater than 20. So what is the most likely cause of the patient hyponatremia? Cerebral salt wasting syndrome, iatrogenic fluid overload, cranial diabetes insipidus, okay, syndrome of inappropriate antidiuretic hormone, and adrenal insufficiency. Okay, normally our thinking is that whatever we heard most, we said this is the diagnosis. It can be also true, but my purpose is not just to make the diagnosis, but to reach the conclusion how to approach these patient, okay. Normal value of osmolarity you cannot hit 290 or 300, it is hypoosmolar. So to discuss this topic we need to understand a lot of things, so please be very much focused. Tell me fast, what is the formula of osmolarity? What is the formula of osmolarity? Today if you are very much, sincerely watching this lecture, I promise you that you will solve all the question of SIADH, cerebral waste disorder, adrenal insufficiency regarding hyponatremia. So please very much don't just bother about the answer. Answer will be of course clear. Osmolarity is how much? 2 into sodium. What is the formula? Can anyone tell me what is the formula for SIADH following assays? Yes. What is the formula of osmolarity, blood osmolarity or plasma osmolarity? Can anyone write down in comment section? You all know this formula. 2 into sodium plus what else? Blood glucose upon 18 plus BUN, blood urea nitrogen upon 2.8. In cerebral salt wasting syndrome, there will be hypervolemia. So option rule out. Yes, Avinash, you are close to the answer. Let me discuss one by one. So you can see that osmolarity is around 290. Osmolarity is around 290, and sodium is around 140. So you can say out of 290, 280 is because of what? It is because of sodium, isn't it? Yes or no? So whenever there is hyponatremia, there should be hypoosmolar or hyperosmolar. What do you think? Whenever you are having hyponatremia, there should always be hypoosmolar or there can be hyperosmolar also. Please answer me. It is hypoosmolar hyponatremia. There can also be euosmolar. There can also be euosmolar. Osmolarity is okay, same. Hyponatremia. And there can also be hyperosmolar. So are they present or not? Is there any possibility that there is hyponatremia and there can be hyperosmolar and euosmolar or not? Actually they can be. But this is what is called as true hyponatremia. This is called as true hyponatremia. Yes, very good. And these two are false or pseudo hyponatremia. Which is the better term, euvolemic or euosmolar? Euvolemic is different. I will come to that. Okay, don't get confused. Euvolemic, hypervolemic and hypovolemic, these are different. I will come to that after that. So that is why I am bringing this topic into your notice, that we get confused with the euvolemic, hypervolemic, euosmolar. These two are different terms. Okay, so let me finish this. Hyperosmolar is also a type of pseudo. These two are pseudo hyponatremia. Yes, I am explaining it. Pseudo hyponatremia. Yes, Avinash, I am coming to that point. Suppose that this is your blood. Of course, these are your RBC and this is your plasma. Okay, this is your hematocrit. Suppose that there is increased protein, there is increased amount of protein. There is increased amount of protein. So whatever sodium is present will be diluted or not? Yes or no? Till here it is. It will be diluted or not? Whenever there is increased protein, suppose it is multiple myeloma. Whenever there is increased protein, for example, in case of multiple myeloma, okay, sodium will be a bit diluted, isn't it? So when you measure sodium, comparatively it will be hyponatremia. Yes, you are correct, Avinash. You are correct, because of this protein. And the second cause is fat. For example, someone is having more than 500 triglyceride. Suppose someone is having more than 500 triglyceride. This can also create a fallacy of diagnosis, because you will feel that patient is having hyponatremia. Yes, Dharuni, you are correct. So in both cases, you can see whenever there is more protein or whenever there is increased triglyceride, it is called as eosmolar. It is called as eosmolar hyponatremia. It is clear till now or not? It is clear till now? This topic is very, very important. And this is pseudo hyponatremia. This is one type of pseudo hyponatremia, because actually sodium is same in amount, but because of increase of protein or increase of triglyceride, you are taking this into amount. You are taking into amount because osmolarity is because of what? Sodium, glucose, and blood urea nitrogen. So there is no increase in osmolarity. How can osmolarity be affected by protein and triglyceride? Am I clear or not, Avinash? Yes or no? Now coming to the second point, hyperosmolar, like suppose that there is uncontrolled type 2 diabetes mellitus, for example. If there is more of glucose, in your blood circulation. Now if you remember the diagram of our total body water, 2/3 is intracellular and 1/3 is extracellular. Okay, if there is increase in the concentration, if there is hyperosmolarity like this, water will shift from where? Water will shift from where? Who will tell me? Water will go from ICF to ECF or ECF to ICF. This is your ICF. This is your ECF. Now tell me, if there is more sugar in the ECF or any other thing like glucose or mannitol or glycerine, where will be moment of water? What is the moment of water? Yes. So you know that water move from lower concentration to higher concentration. So this will be your curve. Very good, excellent. This will be your curve. So there will be dilutional hyponatremia, yes or no? There will be dilutional, because of excess movement of water. There will be dilutional hyponatremia, yes or no? Although actually there is similar amount of sodium. Now listen very carefully. Sodium is not altered. It is not actual true hyponatremia. In that case also, euvolemia also, and in this also. So these two condition is called as pseudo hyponatremia. Till now it is clear. So this is the only true hyponatremia. This is the only true. After that I will come to that point. What is true hyponatremia? This is the okay. Any doubt, please ask me. If any doubt, because even one step is skipped, it will be all wrong. So this is true hyponatremia. Till now it is clear. Now coming to the discussion of true hyponatremia, or the actually it is called as hypoosmolar. It is actually hypoosmolar. So hypoosmolar hyponatremia is the only true hyponatremia. It is clear till now? Okay. So this is true hyponatremia. Repeat mannitol wala concept once again. Okay. Yes, proteins, and see, in mannitol, if it is mannitol given to you and glucose given to you, there is movement of water from ICF to ECF. So there will be dilution or not. That is why mannitol is given, you know already. And if you know 100 milligram increase in the blood glucose decreases how much sodium? Who will tell me? Decreases how much sodium? Decreases sodium amount how much? Tell me. 1.6 milliequivalent of sodium. So this you should know. Yes, it can be up to 3 milliequivalent also, but this is the actual value you should remember for your exam. There is a range of 1.6 to 2.4, but this is the value If there is more, suppose that someone is having 300 milligram per deciliter of glucose. Okay, so suppose 200 milligram is excess. So 200 into 1.6. So you can see 2.6 into 2, it will be how much? 3.2 degrees. Suppose patient is having 140 milliequivalent, there will be degrees of 3.2. It is like this. So whenever there is increase in the amount of glucose, there is decrease in the sodium. And this is not true hyponatremia. That is why this is the first. If you see the, there is a diagram given in Harrison and also UpToDate.com. If you see, the first thing which you should do is that see the corrected sodium, and corrected sodium by what? Glucose. So first measure the blood glucose. If there is 100 milligram increase the blood glucose, it will decrease sodium by 1.6. Is this clear, Avinash? So this is not actual hyponatremia. This is what? Because glucose contribute to the 3 milligram, not 3 milliequivalent, not 3 milligram. It is 3 equivalent. It is 1.6 milliequivalent. Suppose that you are having 140 milliequivalent per liter of sodium. So it will be decreased by 1.6 like this. Okay. Is this clear? So first of all, let me recap this, then I will move forward, otherwise you will get confused. The first point I want to emphasize that osmolarity is mainly because of sodium. So when there is hyponatremia, there should always be hypoosmolarity. But there are various conditions of false hyponatremia. In one case, there can be increased protein like in multiple myeloma. In increased triglyceride, it can cause pseudo hyponatremia because of the things I have shown you here. And in case of hyperosmolar, for example, there is more increase of glucose or mannitol, or if you remember about TURP, what is TURP? Transurethral receptor resection of what? Prostate. There is dilutional hyponatremia because we are using glycerine. So glycerine is taking out the water. So there is more and more water intoxication. So that can also cause, there is one other question in surgery book. If you see that TURP can cause pseudo hyponatremia. So these all are hyperosmolar pseudo hyponatremia. Now coming to the true. This is true. अभी तक जो हमने डिस्कस किया that was all false. Now coming to the true, hypoosmolar hyponatremia. Is this clear till now? Please give me a thumbs up if it is clear. Now it can be, now coming to your point which you were asking, euvolemic, hypervolemic. Now coming to 3 point, it can be hypovolemic. It can be hypovolemic, hypoosmolar hyponatremia. It can be euvolemic, hypoosmolar hyponatremia, and it can be hypervolemic. It can be hypervolemic, hypoosmolar hyponatremia. See, this is like a Dungeons and Dragon. It is a game. If you are interested in this game, then it is very easy to make the diagnosis of SIADH, cerebral wasting disease. There are a lot of diseases. There are 30 differential diagnoses which can only be solved by this game approach. Okay, so in this hypovolemia, of course you can see body water is what? Body water is less. In this body water is more. In this body water is so much that it can cause edema also. It can cause edema also. So point number 1, in hypovolemia, there can be clinical symptom like sunken eyes and all. Patient will be dehydrated. In this patient will be normal. In this patient can have edema. It is a clinical findings. Now coming to the first one, hypovolemic hyponatremia, there are two conditions. In one condition, you can see urinary sodium is more than 20 or less than 20. If it is more than, see, this is clear that salt is wasted. But where this salt is going, from where this salt is going, is this clear or not? Is it going from the kidney? Or some other sources? So in this case, there can be renal loss. Because you can see sodium in the urine, isn't it? In this, there can be extra renal loss. Sodium is lost, isn't it? Sodium is lost. Euvolemic will have increased water or same water. Little bit increased water, but there will be no edema. Little bit increased water. Although it is euvolemic, little bit water will be more because there is absorption of water. But in this, there is lot of increase in water. It can cause edema. There will be no edema in this. Okay, is this clear? Okay. So renal loss. If you see renal loss, and there can be extra renal loss. Okay. Now, if it is renal loss, this can be because of what? Cerebral salt. It can be because of cerebral salt wasting syndrome. Cerebral salt wasting syndrome. Volume is normal, then why upward? Volume is normal, but bit volume is high. Bit, small amount of increase. So you can say only one arrow is there. In this there are 3 to 4 arrow. So only bit, that is why I have increased water is there. Only small amount of water will be there, that will be not visible. Okay. Now after coming to, this is not FeNA. Saptarishi, don't confuse with the FeNA. This is urinary amount of sodium. Yes, Kaushal Kishore, I am coming to that point. If you give me please 20 minutes, then I will come to all the point. What is cerebral salt wasting? What is SIDS? But please give me 20 minutes. Okay. This is cerebral salt wasting syndrome. In this, there can be subarachnoid hemorrhage. There can be history of subarachnoid hemorrhage. There can be trauma. And this will cause release of atrial natriuretic peptide. There can be release of atrial natriuretic peptide. But the main point here is that there can be history of trauma and subarachnoid hemorrhage. Now, renal loss is very, very high. And in this, there can be extra renal loss like vomiting, like diarrhea, like there can be burn, there can be trauma, there can be pancreatitis. So just see. So just measure number 1 osmolarity, number 1 sodium, number 3 urinary sodium. If you can measure this, you can make so much diagnosis, differential diagnosis. Okay. Don't worry. Yes, it is not FeNA, it is urinary sodium. Okay. Now, in coming to euvolemic hyponatremia, second is what? Second is of course euvolemic hyponatremia. In this condition, there is always sodium loss more than 20. Now, who will make the diagnosis of this? There can be 3 most important causes. There are 3 most important causes of euvolemic hyponatremia. Who will enumerate for me? Who will do it for me? Yes, Dharuni. Yes, very good, excellent. Number 1 is SIADH. Excellent. Very good. It means you know this topic very good. SIADH. Number 2, hypothyroid. Very good, excellent. Arshad, very good. Hypothyroid. Not only hypothyroid, severe hypothyroid. Which can cause myxedema coma. It can also cause myxedema coma. Excellent. And the third is what? Please tell me. Adrenal insufficiency. Very good. It is adrenal insufficiency. Very good. Excellent. Addison disease. So Saptarshi Das, very good. Addison disease. This topic is little bit more detailed. So just go through me. After that, you will get the recorded session of the video. Please go through again and make the notes. First listen to me what I am telling you. So when there is euvolemic hyponatremia, there can be SIADH, there can be hypothyroid, and there can be adrenal insufficiency. So there are the three causes. Now what are the causes of hypervolemia? What are causes of hypervolemia? Who will tell me? Hypervolemic hyponatremia. What are the main three causes? In this condition also there can be two. Very good, excellent. Arshad, very good. If sodium in the urine is more than 20, if sodium in the urine is less than 20, yes, that's very good, Dharani, that's very good. Now what is the answer? If sodium, see, if kidney failure is there, very good, excellent. If kidney failure is there, your preparation is really very good. You are going to get a very good rank this time in AIMS. Acute or chronic renal failure, because when there is renal failure, sodium reabsorption is hindered. So sodium, although GFR is less, but sodium is coming in the urine, so there can be acute and chronic renal failure. And if sodium is less than 20, then there can be RAS activated system. For example, number one, like nephrotic syndrome. Very good. Why nephrotic syndrome? Because there is albuminuria. If there is albuminuria, so there will be edema. Because albumin will not be there, so it can cause edema. So there can be hypervolemia. Number two, congestive heart failure. Never ever forget these 3 points. And number 3 is what? Cirrhosis of liver. So these are 3 conditions in which you can get hypervolemia along with that hyponatremia. Now please, coming to that question, first come to the question, then I will again discuss. Coming to the question, in this question what you are seeing, this is hypoosmolar or hyperosmolar? This is hypoosmolar or hyperosmolar? You can see it is what? Hypoosmolar hyponatremia, isn't it? It is true hyponatremia or false? First of all, tell me, it is true hyponatremia or false? Is it true or false? True. So first point is obvious that it is true because osmolarity is less. It is less than 300. So one point is clear. Number two, BP is high. BP is high, or you can say on the upper side, and also you can say net fluid is there. It is euvolemic or hypervolemic. I mean euvolemic or hypovolemic, sorry. Hypo or eu. Sodium is also low, yes. Hyponatremia. Hypoosmolar hyponatremia, yes, very good. And what about urinary sodium? It is more than 20. It is more than 20. And it is urinary osmolarity is also more than 100. So urine in osmolar. So this is example of what? Hypoosmolar or hypovolemic or euvolemic. Excellent, very good. It means you are getting me. Although this topic is little bit tough and you are getting, that is very good. Euvolemic. And what is the differential diagnosis of euvolemic? What are the differential diagnoses of euvolemic? I told you. What are the differential diagnoses of euvolemic? Number 1 is SIADH, never forget. Number 2 is what? Hypothyroid. Number 2, hypothyroid. And number 3, adrenal insufficiency. Very good. So in this case, what can be the answer now? Myxedema coma. Very good. Myxedema coma. So what do you think in this case? Cerebral salt wasting syndrome. What was that? Cerebral salt wasting syndrome. What was that? Hypovolemic or euvolemic? That was hypovolemic. That was hypovolemic hyponatremia. Yes, very good. Now, SIADH and adrenal insufficiency. These two are what? These two are, of course, euvolemic. Euvolemic hyponatremia. And this is psychological polydipsia. How can you overrule psychological polydipsia? Who will answer me this? How can you overrule psychological polydipsia? Some persons are very fond of taking water. What about urinary? What about urinary osmolarity? What about urinary osmolarity? That will be less or that will be more? Yes, water deprivation test. Very good, excellent. Very good, Vasavi, very good. Now, so now what is your diagnosis? What is your diagnosis of this question? Ultimately, it is not cerebral salt wasting. It is not cerebral salt wasting because it is not hypovolemic. BP is less or more. In this case, BP is less or more. Patient is hypotension or hypertension. In this case, you can see patient is having hypotension or hypertension. More, very good. BP is more. So it cannot be cerebral salt wasting syndrome. It can never be cerebral salt wasting syndrome. Now, coming to point, how to differentiate between SIADH and psychological polydipsia. If you want to discuss this, if you want to go through that detail, yes or no, please tell me. I know this is very, this is a lot of information, I know. In only half an hour, there is a lot of information for you, but this need to be done before examination. Okay, so let me go into more detail than that. What are characteristic of SIADH? Very good. So you all are interested. That's really nice. What is SIADH? SIADH, of course, there is hyponatremia. There is volume expansion without edema. There is volume expansion without edema. Okay, and there is natriuresis. These all are very important points. You have seen all this. I am just summarizing this. Euvolemic, yes, very good. It is euvolemic hyponatremia. Okay, then one point I want to ask you: what about uric acid? What about uric acid? It will be low or high? What about uric acid? It will be low or high, and why? Why uric acid is low or high? Because you all are very good scholar. That is why I am discussing all these points. These are very important rank for your rank, because these are those points which is very great to know. If you know this, this is very good. Uric acid is low or high? Yes, Dharani, Arshad, Jagruti. How euvolemic, please, and tell me. Okay, so let me discuss this question of Dr. Sarmad, that why euvolemic. Let me tell you that this is your principal cell. Now let me discuss very basic thing. This is the principal cell. These are your aquaporin 3 and 4. If you remember, these are your aquaporin 3 and aquaporin 4. Aquaporin 2 is normally not present. So these are your ADH. When ADH is more, in SIADH, syndrome of inappropriate ADH is more, and aquaporin 2 will come on this side. Now, lot of water is reabsorbed. So it can cause edema. Yes or no? It can cause edema or not? But question of Dr. Sharma is that why there is no edema? Because if you remember about the Bain-Bridge reflex. What is Bain-Bridge reflex? Do you remember about Bain-Bridge reflex? When there is a lot of fluid overload, atrial natriuretic peptide is released. atrial natriuretic peptide is released, and that will cause excretion of water also and sodium also. Is this clear or not? That is why there will be no edema, and that will become euvolemic. Now your doubt is clear or not? This is called as ANP escape. Yes, very good, Dr. Sampath. Escape phenomenon, excellent. This is not aldosterone escape. Mind it. This is ADH escape. Okay. Aldosterone escape is also there when there is when in the Cone syndrome, when there is lot of ADH, when there is lot of aldosterone, that is also present. But in this is because of ADH, that your body is ignoring the excess ADH. So that is aldosterone escape, and that is ADH escape. Your body is escaping the excessive ADH. Any role of ANP in this natriuresis? Yes, this is the role of ANP. What I am telling you, this is the role of ANP, or brain natriuretic peptide. Okay, so now there will be no edema. So coming back to the SIADH, there will be hyponatremia, there will be euvolemic hyponatremia, and volume expansion without edema. Because of what? Because of ADH escape phenomena. Okay, natriuresis. Why? Because of atrial natriuretic peptide. Now who will tell me why there is hypouric acid? Who will tell me why there is hypouricemia? Can anyone tell me? Due to peritubular vasoconstriction. Due to peritubular vasoconstriction. Actually, I am telling you why it is so. See, how many receptors of ADH are there? ADH has 3 receptors, V1, V2 and V3. So it is acting on V2 via in kidney. In kidney it is acting on V2. But V1 is on blood vessel. V1 is on blood vessel, if you remember. So there is a lot of ADH. There will be not only absorption of water, but also vasoconstriction of your peritubular vasoconstriction. That will decrease your uric acid. Is this clear? Because ADH has 3 receptors. It is not working only on kidney, but also on your blood vessels. So now water loading test is done to differentiate it from water loading test. If you give lot of water, ADH is normally what? ADH is suppressed. Okay, and if ADH is normal even after giving lot of water, it is more, then patient is having SIADH. Patient is having SIADH. Is this clear or not? Am I clear or not? It is clear till now or not? Okay, so in this condition, what you give? What is the drug of choice? What is the V2 receptor blocker? What is V2 receptor blocker? Who will tell me? Who will tell me V2 receptor blocker? Yes, Dr. Sampath. What is V2 receptor blocker? Yes, very good, excellent. They are VAP10. They are conivaptan. Yes, very good. That's really nice of you. Conivaptan. And second is tolvaptan. Very good. So now let me revise this whole thing together. Let me revise this. Please go with me. We have discussed that hyponatremia can be true or can be false. False can be either hyperosmolar or can be euosmolar. Euosmolar is mainly because of increased protein, increased triglyceride. Hyperosmolar hyponatremia can be because of glucose, mannitol, and also in TURP, transurethral resection of prostate. there is water intoxication, and that is because of dilutional, because water will be taken from intracellular compartment to the ECF. So sodium will dilute. Sodium will dilute. Okay, I will come to your point. I will come to your question, Aisha. So after that, so now coming to true hyponatremia. Now coming to true hyponatremia. In true hyponatremia, there can be three. One is hypovolemic, second is euvolemic, and third is hypervolemic. Hypovolemic can be dehydrated. Coming to your question, Dr. Sarmat, hypovolemic will be having sunken eyes and patient will not be hemodynamically stable. In euvolemic, patient will be normal. In hypervolemic, there will be edema. So if you remember in this question, there is no edema. No edema is given. Is this clear? BP is kinda normal. Yes, BP is very good. Zarani, your answer is almost correct. BP is normal and there is no feature of edema. Otherwise, there should be a mention of edema in the patient. If it is of CHF, it is of nephrotic, there should be always mentioning of the edema. But there is no mention of edema. Okay, now coming to this hypovolemic hyponatremia. It means sodium and water both are lost. It is very simple concept that sodium and water both are lost. So this sodium is lost from where? From kidney or something else. If it is kidney, so it is the most important cause is cerebral salt wasting syndrome, and it is most commonly associated with subarachnoid hemorrhage. In this question, they try to confuse you because they have given history of subarachnoid hemorrhage. So if you know subarachnoid hemorrhage is associated with cerebral salt wasting, you will take that answer. But in that case, hypovolemia is there. But in this condition, BP is normal, fluid is normal, there is no edema. Okay. Now point number 2. In euvolemic, there are mainly three diagnoses. Where it is. Okay. See, in euvolemic hyponatremia, there can be SIADH, hypothyroid and adrenal insufficiency. Yes, Venugopal, it is very tricky question, but if you understand this, you can solve all the question. After this session, just go through your previous MCQ. There are 20-25 MCQ on this topic only. You can solve those. So in euvolemic hyponatremia, you should remember also it is a one-liner question also. In euvolemic hyponatremia, there are mainly three diagnoses: SIADH, hypothyroid and adrenal insufficiency. There is no mention of ACTH. There is no mention of this. That is why if in ICU setting, a patient come to you hyponatremia, okay, don't always think patient is SIADH. Patient can be myxedema coma. So always measure TSH. Thyroid profile test should be done always. Otherwise, you will treat like SIADH and patient will be myxedema coma. So these are the three differential diagnoses of euvolemic hyponatremia, and all will have unit sodium of more than 20. Dilutional hyponatremia is hyperosmolar or no, that dilution is different. See, pseudo wala different tha. In case of pseudo, glucose was taking more, and in this case it is different. I am coming to your point. So there are 3 DD of euvolemic hyponatremia. One is SIADH, other is hypothyroid, and third is adrenal insufficiency. So if a patient coming to you normal, no edema, and there is no sunken eyes and no dehydration, no edema, no dehydration, euvolemia. If there is no mentioning of edema, there is no mentioning of dehydration, it is euvolemia. BP is normal, BP is not less. Yes, very good, you are correct. So BP is normal. So SIADH, hypothyroid and adrenal insufficiency, these are very important. So it is very easy to diagnose the case. Just measure this addition for addition disease, and for thyroid disease you just put the lab diagnostic test, and if it is not, if thyroid is normal, if there is no adrenal disease, then of course it is SIADH. Yes, I am coming to your point also. This is actually at least 4 hours are needed to discuss this topic, but I want to summarize very important details. Okay, I will come to your point also, that there are drugs which can cause SIADH. There are drugs which can cause hypovolemic like thiazide. So you should also rule out the history of drug. If patient is taking drug like Bartter syndrome like case, or Gitelman syndrome like case, or there is thiazide diluted drugs, so they can also cause hypovolemic hyponatremia. I have given broad category. You can fill all those categories. For example, in SIADH, there are so many drugs which can cause SIADH. So this is the broad category. It will help you see. If you pick tree by the forest, okay, you will forget. Just have a broad view that this is forest. Now you can pick the tree. So you know broad view. Broad view is what? Hypovolemic hyponatremia. In this there is euvolemic, hypovolemic and hypervolemic. If hypovolemic hyponatremia, renal cause, extrarenal cause. If euvolemic, only three: SIADH, hypothyroid and adrenal. If there is hypervolemic, either there is UNA more than 20 or UNA less than 20. If there is sodium release from the kidney and patient is having edema, most of the cases are because of acute or chronic kidney failure. But if there is no release of sodium from the urine, patient can have mainly three conditions: nephrotic, CHF and cirrhosis. So these are the broad category by which you can pick the trees. So this is the technique to learn something, that pick tree from the forest. First know this is the whole forest, and these are four types of tree. These are green tree, these are dead tree, these are like this. So by this you can pick up. So if you know broad category, hyponatremia, true hyponatremia, pseudo hyponatremia. Pseudo hyponatremia because of what? Lipid, triglyceride, protein, glucose, mannitol, glycerine. True hyponatremia, three types: hypovolemic, euvolemic and hypervolemic. If it is hypovolemic, renal cause, extrarenal cause. Renal cause, most important, cerebral salt wasting syndrome. In euvolemic, three cause: SIADH, hypothyroid and what? Adrenal insufficiency. Hypervolemic, two cause: kidney failure or this nephrotic CHF and cirrhosis. So you, in 5 minutes you can revise all this DD. In this 5 DD you can pick all those. SIADH can be caused by drug, okay. Then extrarenal cause can be barter. Yes, Shivalik, barter, Euthelman, needles, quick revision. FENA is mainly for differential of pre-renal, renal and post-renal cause. It is different from this topic. I will pick that sometime other. Vinogopal. FENA is mainly for pre-renal, renal cause of kidney failure. Okay, it is different from this. In this I am taking about sodium release from the urine. It is UNA. It is not FENA. Okay, so you are asking about diuretic. See, it can also be because of, because you are asking, otherwise it will be too much detail. Let me make it more clear. In renal cause, there can be cerebral salt wasting syndrome, number 1. There can also be diuretic loss. So diuretic loss can be presenting to you like hypovolemic hyponatremia, and this can be similar to like Barter and Gitelman. And you know, mutation of sodium potassium chloride create Barter, and mutation of sodium chloride causes Gitelman, and gain of mutation of ENAC causes Liddle syndrome. So you all know those facts. I know that. So this is in brief. If any doubt you can ask me among this point. Otherwise it is a whole topic. I cannot discuss whole kidney and all those. But if you want to discuss in this point regarding hyponatremia, all those MCQ regarding hyponatremia, I promise you that you can solve all those differential diagnosis if you know about this hyponatremia. So this question was very tricky, and thanks Dr. Sampath. He has given me this question, and I find very useful question. That is why I put this question in this today session. And that you can see that creatinine is also lower side. So there are a lot of hint of hyponatremia, hypoosmolar, hyposodium, urine osmolarity is more. Otherwise it can be psychological polydipsia also, but urine osmolarity is high. In psychological polydipsia, your urine will be dilute, isn't it? So if any doubt you can ask me, or I should finish this session. Yes, myxedema is actually in hypothyroid there is decrease in hypothyroid. It is incomplete understood mechanism, but there is decreased T4. If there is decreased T4, if you know, in myxedema coma, thanks a lot. In myxedema coma, there is severe form of hypothyroid, and your BMR is so low, EGFR is so low. Your EGFR is so low that it present like hyponatremia. So in myxedema coma, if you remember, there will be hyponatremia, there will be hypothermia. If you remember this, there is hypothermia, there is hyponatremia, and there is bradycardia. This bradycardia causes decreased GFR. This decreased GFR. So all you know that, and you know the management also. We used to do 300 microgram stat T4 and then manage the case by giving 100 microgram OD, thyroxine OD. So you know about the treatment also. We should not correct hyponatremia. It can cause reverse case. It can cause various problems in the brain. If you remember that, can anyone tell me if you eagerly correct this, what can it can cause? Who can tell me? What can it can cause? If you eagerly correct this hyponatremia, it can cause what? Anyone? Why this should not be correct? Yes, very good. Venugopal, pontine malign. Very good, beautiful. That's very really nice discussing with you all, because you all are having a good level, so I can discuss this. Treatment by 3% NaCl, very good. Otherwise, it can cause severe central pontine manular lysis. Very good, excellent, beautiful. This was very nice discussing with you all. Someone has asked me about dilutional hyponatremia. See, in case of, suppose that this is your ICF, 2/3 is ICF and 1/3 is ECF. If you give hyperosmolar water, okay, this is hyperosmolar. For example, if there is a lot of glucose, water will come like this. Water will come in the ECF. Water will come in the ECF. So sodium will be normal in amount, but this sodium is diluted in the water. So that can cause dilutional hyponatremia, that is pseudo. So very good. Is there any other doubt? Any other doubt? If you want to discuss any other thing in this, because this topic is very important. Can anyone tell me how to differentiate between central and nephrogenic diabetes insipidus? Can anyone tell me to differentiate between central diabetes insipidus and nephrogenic diabetes insipidus? Yes, thanks Dhanani, thanks for your compliment. Yes, physiology is the base of medicine. It is like a spinal cord to the medicine. If you understand one's physiology correct, only thing you need to understand about the pathophysiology and about the treatment. Yes, very good, excellent. Desmo plus interest. Desmo plus interest. Okay, very good. So you know this, that is beautiful, because in this desmopressin test, what will be there? If it is central diabetes insipidus, in which ADH is less, if you give ADH, everything will be okay. Everything will be okay. If it is remain unchanged, it is nephrogenic diabetes insipidus, because there is mutation of aquaporin 2. This was question of last year NEET PG. Yes, Pamita, so dilutional hyponatremia will come under the heading of hyperosmolar hyponatremia. Yes, you are correct now. Absolutely correct. So this is about the basic concept of physiology, which will help you to understand medicine. Okay. There are beautiful lectures by Dr. Dilip and Dr. Rajesh Gubba. They are taking excellent lecture of medicine. So please do attend those lecture of medicine. So this is my help towards that. So just V2 mutation. Yes, V2 mutation. Okay. So thanks a lot. Thanks a lot for this today's session. And if you like this video, please like this, of course, and share it with your colleague if you want. And if you are an Unacademy student, you know there are so many courses going on. From 9, 10, there are so many courses. So we are going to discuss FNG also. Then there are PGI session, there are JIPMER session. So you can join Telegram group of, USMLE, this Unacademy. Yes, Dr. Sampath, in nephrogenic receptor are resistant. Yes, in nephrogenic receptors are not working properly, and there is mainly at the level of V2 receptor. There are V1, V2, V3. So V2 is mutated and there are aquaporin 2 mutation. So those resection are, yes, Aisha, please equation. Which equation you want? Which equation you want? Please tell me. Yes, what is your question, Dr. Samath, which equation you want? Osmolarity, blood osmolarity. It is equal to 2 into sodium plus blood glucose upon 18 plus blood urea nitrogen upon 2.8. This you want. I was, by this equation I want to explain you that osmolarity is around 290, and because of sodium it is 280. So most of the osmolarity is because of sodium. It is also because of blood glucose also. That is why it is getting hyperosmolar hyponatremia. But I want to explain you that osmolarity is mainly because of this sodium. Okay. Which first one? This is the only equation I have discussed. Aquaporin 2. One is present in PCT. Saulik Das, one is present in PCT. Okay, this equation I have discussed. So it was very nice discussing with you, all of you. So thank you, and please, my request is there, because this is a complicated topic. This is very easy topic, but just go through this lecture again and just write down few points. Like this is hyponatremia, true. This is pseudo. In true, there are three: hypervolemic, hypovolemic, and euvolemic. In hypervolemic, it can be renal failure, it can be nephrotic, it can be all those things, liver disease. In euvolemic, it can be Siadh, myxedema coma, or it can be adrenal insufficiency. Okay, so like this, just revise this topic, because this is called as Feynman technique, Dr. Feynman technique. Dr. Feynman was a Nobel laureate, and he said that if you can explain it in the simple language, then only it means that you understood. So please make a white paper, blank paper, and try to recollect what we have discussed here. Try to recollect that today we have discussed about hyponatremia. So please write down all those things together in the one paper. It will all be summarized in only one paper, and it will need only 2 minutes to revise that. Okay, so thanks a lot, and please make more and more questions, so in next session we can show that. So please like this video and share with your colleague. Thanks a lot.